Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Charles Hawley, NAUTO's Director of Projects.
Thank you, Mara, and thank you all for being here. I'm happy to welcome everybody to today's session, using linked health data sets for population health science. Something that's near and dear to my own heart. This is a joint session with IAPHS, and I wanted to mention and say thank you to our sponsor, Stern Consulting. And then I will introduce today's moderator, Sara Hallvik of Comagine Health. Sara?
Yeah, thank you, and welcome everybody. We have three great presentations teed up for you today, and we're going to kick it off with Félice Lê-Scherban. Félice is an assistant professor in the Department of Epidemiology and Biostatistics at Drexel University's Dornsife School of Public Health, where she also leads the training core of Drexel's Urban Health Collaborative. She received an MPH in Epidemiology and Biostatistics from the University of California, Berkeley, and a PhD in Epidemiology from the University of Michigan. Her research centers on health disparities with a focus on children's health disparities, life course determinants, and immigrant health. Her work has examined intergenerational socioeconomic influences on mental and physical health, neighborhood social context, and cardiovascular risk among immigrants. So today she's going to be presenting on using linked electronic health records for children's health disparities research. Go ahead, Charles.
My name is Félice Lê-Scherban, and I'll be talking about using linked electronic health records for children's health disparities research. Now, just to start, what do I mean by health disparities and health disparities research? I like this definition of health disparities by Paula Braveman, who describes them as potentially avoidable differences in health. And these differences systematically place socially disadvantaged groups at further disadvantage on health. So when I'm referring to health disparities research in EHR, in this context, I'm specifically talking about trying to quantify these differences, quantify these disparities between groups in health or in healthcare. And we can see and we can quantify disparities along multiple different dimensions, three that we estimate and often and see disparities according to our gender, race and ethnicity, and socioeconomic status. Now, there are a lot of pros to using EHR data for health disparities research, including pediatric health disparities research. It's low cost. They're very large samples. There's often longitudinal data when patients are seen multiple times over time within the healthcare system. There's no participation bias. Now, there is selection bias in terms of who is a patient in the health system, but presence does not rely on an explicit participation to participate in consent to participate in research. And also EHR are extremely comprehensive across health conditions. However, there are also a number of challenges. One is that transient and mild conditions may not be documented in the EHR. This is a major problem for health disparities research using EHR. There's a lack of robust behavior and social determinants of health data. I'm going to talk a little bit more about this specifically, but there's often a lot of measurement error, including just measurement of the disparities populations themselves. as well as problems with missing data and diagnostic inconsistencies. Data privacy can be an issue. Estimating time can be difficult because there's no set duration of time between visits often for patients. And generalizability to the wider population can be challenging. It's not always necessary. Sometimes, for example, for quality improvement use, you just want to limit interpretation to the patient population itself. But for broader generalizability, that can often be challenging. And we can also have problems with algorithmic bias, where the presence of certain patients in the data and the way those data are used to build models, and then the deployment of those models can in fact entrench disparities that are already present instead of working to reduce them. So I mentioned this issue of defining disparity populations in the EHR. So starting with gender, for example, the most salient gender as a social construct is often the most salient in terms of identifying disparities, but EHR systems often don't include a measure of gender and rather just include a binary measure of biological sex. For somewhat similarly for race and ethnicity, the way that this information is collected and how often it's collected and how completely it's collected varies a lot between health systems. And for socioeconomic status, which is the focus of much of my research, unfortunately, many EHR systems contain no direct measure of SES for patients or their families. I would consider, a direct measure would be something like education or household income. Those measures are often just simply not available in the EHR. So we rely on proxy measures. And the two most common are insurance payer, which is a proxy for household income because of income-based eligibility for public insurance, and area level SES. And this is where a patient is assigned to a certain area, be that a census tract or a zip code, based on their residential address. And then we use the census to derive an area level measure of SES, like poverty or median income, and attribute that area level measure to any patients living within that community. This gets even more complicated when we're trying to measure disparities in child health. And that's because these proxy measures of SES often differ between children and adults. So for example, for insurance payer, the income eligibility for children for public insurance is different than it is for adults. And when we're using these neighborhood SES measures, there's often a different relationship between household SES and area level SES for families with children compared to families without children. One example of this is that many households with children are going to make residential decisions based on the availability of good schools. So that was kind of an overview of some pros, some cons, some challenges. I'm going to describe now a specific disparities-focused project that we recently completed called the Pediatric Big Data Project. This was a collaboration between Drexel University, the Children's Hospital of Philadelphia, and the University of Pennsylvania, and it was funded by the Pennsylvania Department of Health. And the purpose of the Pediatric Big Data Project was to use big health data methods to elucidate novel factors related to the causes of pediatric asthma, childhood obesity, and avoidable hospitalizations, as well as disparities in these outcomes. And so to complete this project, what we did was we built a large linked database. And the basis for this database was the EHR system for the Children's Hospital of Philadelphia. And I'm referring here not just to the hospital itself, but to the entire integrated pediatric network. So this is 30 plus inpatient and outpatient practices throughout Philadelphia and the surrounding metropolitan area. So we used essentially the entire EHR for years 2007 to 2017. The database contains information on almost 1 million individual children. And then what we did is for each visit of any kind, for each child, we extracted the residential address from that visit, geocoded it, and linked it to a whole host of environmental measures. So this ranges from environmental exposures like pollen, weather, air pollution, to measures of the built environment, like traffic, access to green space and parks, access to healthy retail food or to unhealthy food like fast food outlets, excuse me, as well as measures of the social environment like safety and crime and residents' perceived social cohesion in the community. And then finally, the last piece of the last set of information we brought in is we were able to obtain birth records from the state of Pennsylvania for the subset of children in the database who were born in Pennsylvania. So we were able to link in birth records for a little bit more than half of the children. And what that provided is important information on prenatal and perinatal risk factors, and importantly for disparities research, measures of parental education, and parental education is a direct measure of socioeconomic status for children. So we were no longer tied to relying on the proxy measures available in the EHR. So as you can imagine, one of the first things we did was see how parental education, and here we relied on maternal education, relates to those proxy measures. So this graph shows how neighborhood SES, how the distribution of neighborhood socioeconomic status, this is using a multi-factor socioeconomic score based on a variety of census variables, compares to maternal education. And luckily what we see is we do see the patterns that we would expect. So for for children with a mother with less than a high school degree on the left here, the majority of those children are living in the lowest SES neighborhoods in blue. And that proportion of children decreases with increasing maternal education. Whereas the proportion of children living in the highest SES neighborhoods in brown here increases with increasing maternal education. We also saw that actually that insurance payer measure performs as we would expect and pretty well, where as maternal education increased, the proportion of children with public insurance in blue here decreased, while the proportion of children with private insurance increased. So just to give you a snapshot of the kinds of analyses we did here, this was an analysis looking at the prevalence of obesity and looking at disparities by maternal education in that prevalence. So you see two graphs here with girls on the left and boys on the right. And what each of these graphs shows is the prevalence of obesity by age stratified by maternal education. And so the take home is that we do see substantial disparities in obesity at every age, going left to right, where children with the most highly educated mothers, this bottom line here for girls and boys, have the lowest prevalence of obesity, whereas the prevalence of obesity is highest among children with mothers with the lowest maternal education. We can also see that those disparities are larger among girls than boys, and that they increase with age. This is to give you an idea of some of the other recent publications from this project. We're still working our way through a lot of these data. And that's all I have. I'm looking forward to our discussion.
Great, thank you, Félice. That was fascinating. Audience, please share your questions in chat. And while you are typing, I have one question to kick us off here. What special considerations are there for linkage projects pertaining to children specifically, as it compares to linkage projects that might involve adults? You mentioned some about proxy measures and some of the challenges of measuring SES, and wondering if you could say a little bit more about that.
Yeah, sure. So as I mentioned in the presentation, there are some challenges with measures not performing the same or not being the same for children as for adults. Like I mentioned, these proxy SES measures. Some other things just that we are grappling with is that there will be information that's reported, some information reported by a guardian who may not be the same guardian over time, as opposed to by the child, him or herself or themselves. And that depending on their practice, when that switchover occurs, when you'll be getting self-reported measures from the child versus guardian-reported measures can be different. And then something that we have really not found a good solution for yet, but I'd love to hear if others have, is that because children are so embedded in their families and the healthcare decisions are such a family level decision, it's very challenging not being able to link children with siblings or children with parents. So there have been some efforts to do that, and some other projects we've tried using, for example, birth records to link children with parents, but it's a really important linkage and one that's really difficult to do in the context of many EHR systems.
That's great, thank you. Let's go to Jacob's question. How would you describe the value add of your research by including claims information with the EHR plus birth records? Saw that using payer claims could be helpful for proxies, but where were claims in particular useful in your analysis and the production of these novel insights?
Yep, so actually we were not able to include claims information in this project. We were originally hoping to and didn't quite get there. But one reason that I had been hoping to be able to do that was to have more information on care that the kids might be receiving outside of CHOP, or at least be able to quantify how much not having EHR data from other systems might be affecting estimates we were getting using just the CHOP data.
And how do you control for possible change in mothers' education over time?
That's another really good question. We were not able to account for that. That's really an issue in, using birth records as we did, but also using survey data or other kinds of survey, other kinds of education data. On the one hand, it's good that education tends to be relatively stable over time, as opposed to, for example, wealth or income or employment status. But we are not capturing, unfortunately, any information on mothers who have continuing education after the birth of the child. And that's just, I'm sure that's resulting in some measurement error. That's probably especially strong for younger mothers who are more likely to then get additional education.
That's great, thank you. And we will have more time for questions for Félice in the wrap-up Q&A with all of our presenters, but let's move on to our next presenter now. So Ernie Chipley is our next presenter. He is a clinical research director for Vizient, and he works with hospital researchers on clinical research publications and evaluations using the Vizient CDB database, longitudinal study integration with CMS analytical data, and other payer-based data systems. So today, Ernie will be presenting on a variation in COVID-19 mortality and hospitalizations in rural and urban communities.
This NATO presentation is on the differences between urban and rural spread during the COVID-19 pandemic. Gladys and myself are with the Center for Advanced Analytics and Informatics with Vizient. And we'll go ahead and start with the next slide. For this analysis, we added 3 extra indexes. We used ARC's Social Vulnerability Index that looks at socioeconomic conditions. We looked at population health infrastructure. Are there any food deserts? How many providers in that area? And then actually healthy habits around smoking, etc. As we compare the rural versus urban areas, we can quickly see that the deaths per million for the rural areas is twice as high. And also, when we look at the top 10 list here, we see that the highest areas, the rural areas in Lubbock, Texas, and we see New York City is actually only ranked 6. Here are some CBSAs, the urban areas, and we see these mountains here are their adjacent rural areas of those cities and how much higher their mortality is. This graph's pretty important because it looks at both geography, those in the northern latitudes above the 38th parallel, and then counties in the below the 38th parallel in the southern areas. So we see here, using ARC's Social Vulnerability Index, we wanted to look at the high poverty areas in these areas. So you can see quite quickly in the north here, that the majority of the poverty is actually in the inner cities, in the large metro areas. Whereas in the southern latitudes, it's mostly in the smaller towns and in the rural areas. There's also quite a bit more poverty in the southern areas here, about 72% compared to 28% in the northern areas. Now we see the timeline between these two geographies in the north, and then we see a similar one for the south. Orange line represents the poorest, most vulnerable counties. Blue lines are the wealthiest, least vulnerable. We can see the orange, quite a bit larger peaks here in both the north and the south. We also see a much longer spread in the north versus in the south. And we also see a little mini surge in the south here when folks go indoors in air conditioning. We also start to see the role of the Delta variant, much higher spread among the poorer classes compared to the other classes. We know a lot of that has to do with vaccine hesitancy in those economically deprived areas. This map shows us high persistent poverty counties. So these are counties where they've had a high poverty rate for the last 40 years. We see quite a bit of it in the urban areas up here in the north. We see a large area here in the Delta, Appalachia, southern areas, especially around the Texas, California, Mexico borders. We see it in the Indian communities as well. And we see a very big difference, 3,755 deaths per million versus 1,582 for the rest of the country. Now we're looking at hospitalizations. So we took markets in different states where our Vizient database is fairly well represented. And we looked at the differences between the poor economic counties versus the richer, wealthier ones. Using the SVI index, we can see some of these big states like Texas, twice as high. And you see in California, 7 times as high hospitalizations in the poorer areas versus the richer areas. This is looking at San Francisco. We broke down the hospitalizations per million on the y-axis here. Then the social vulnerability index, the least vulnerable, richer, most vulnerable, higher poverty. You can see these high poverty zip codes, quite a bit more hospitalization. You see the lower, least vulnerable, lower hospitalizations. We picked 2 zip codes to look at, both around the same population, and we can see quite a bit different outcomes. This one had hospitalizations per million over 4,000. This one 288 in the same county, 15 times higher. Here we see our county dot map. We focused just on one city to show how the spread dynamics can be quite different just in one town. Here we have deaths per million through July, and here we have about when the surge happened in each county. Using 200 deaths per million as our proxy, we can see the epicenter here, Franklin County, right around June, the surge hit there. But we can see Delaware County here, 6 months later, before they reached that level. Much better socioeconomic conditions, and the #1 healthy county out of 88 in Ohio. Here's our county dots again. Orange is the most vulnerable decile using the SVI. The blue dots are the least vulnerable. We can see very early on, we can see Bronx and Kings County, ground zero, quite a bit of high mortality, over 7,000 deaths per million. You can see in this quadrant here, it's almost all yellow or orange. You can see down here, it's mostly the blues in this area where most folks would want to live. We're looking at healthy counties here, ones that are in the lowest quartile for smoking, obesity, and inactivity. 327 counties, about half of those rural. Of the ones that are rural, their per capita mortality rate was 50% lower than all rural counties, quite significant. We see much slower spread, a lot of it not until 2021. We see much lower mortality overall. This is looking at strong infrastructure. First thing we'll notice is we're looking at the top decile, which out of 3,000 counties in the US should be 300 dots. We're only seeing around 30. This is because we filtered on only the rural areas, but we did see quite a bit of much better outcomes for these with a strong infrastructure when it's possible. This is showing the Northwest area. We can see quite a big difference between urban and rural. A lot of it due to the infrastructure, even the very wealthy blue dots, very high mortality, reaching up to the 7,000 level. Once again, this has to do with the large amount of admission transfers that were done during the COVID. All right, this is on healthcare infrastructure, and we looked at the vaccinations. We took the data as of mid-August of this year, and we grouped all of the counties into ones that are either by low vaccination or high vaccination, both for the urban and for the rural areas. As we can see very quickly, the very high death rate per capita for those that are lowly vaccinated versus the ones that hit our target of 80% of the folks 65 and older. You also see the same thing in the rural side, 153, 40, almost 4 times the mortality rate. We also see that there was a lot less vaccination among the rural areas. That's where we're thinking about looking at this infrastructure scores. See, in the urban areas, they have much stronger urban infrastructure than in the rural areas. So a lot of it gets into whether is it really just vaccine hesitancy in these areas, or could it also be the fact that the supply in those rural areas is diminished. We did see with the Indian Health Services, the great work that they did in those areas in New Mexico, Utah, where they really went out to those rural areas, and they usually are typically, if you look at 2018's flu vaccination rates for 65 and over, it's usually very dismal, around 30, 40%, and they got those all up into the 70 and 80% this year. We covered most of these areas already. Wanted to go over urban-centric bias. Since most of the medical schools are in the north, northeast, and in those areas, quite a bit of the lower socioeconomic patients are in the urban centers. So you see quite a bit of Medicaid expansion, value-based insurance design, Medicare for all, and bundle payments. Those are all solutions, but they're only based on the individual with really good insurance. In these rural areas, we need to have more solutions that are infrastructure in nature. Also, another area that was big was on the admission transfers. 1 out of 3 of our hospitals had 2 types of surges, one for local area and another surge handling the folks from the rural areas.
Great, thanks, Ernie. So much fascinating information in there. Again, if you have any questions, please put them into chat. I do want to kick it off with one though for you. You presented a pretty clear slide deck there with some disparities, significant disparities between areas with higher and lower SBI scores. And within that, I'm wondering if you saw any socioeconomically depressed rural areas that were successful in mitigating the effects of COVID-19.
Yeah, so many public health areas did really good jobs serving these communities. You see really high use of motel vouchers for a lot of the homeless. You see the use of 211 was just exploded during the pandemic in those areas. But one state in particular did really well. You have West Virginia, which is the second most depressed state after Mississippi. You would expect their mortality and hospitalization rates to be right up there with Mississippi and some of those other areas, but it's actually quite lower. And we think that has to do a lot with their focus on infrastructure over the last 20 years has been amazing. So in other parts of the country, you're seeing this increase in nursing home deserts, clinic deserts in the West over the last 10 years, probably I think just in the last 10 years, there was over 200 new nursing home deserts added to the western part of the country. But you see in West Virginia, the exact opposite. They've shut down so many of those deserts and really helped build that kind of infrastructure that you need in those rural areas.
Thanks, and that kind of gets at Imelda's question next. Are infrastructure solutions beyond nursing homes? And could you speak a little bit more to what you mean by infrastructure solutions?
Yeah, so when we looked at infrastructure, we looked at food banks, we looked at how many clinics were locally there, grocery stores, availability. You know, in some areas around Amarillo, those folks, you know, the closest grocery store is actually the mini mart down the street where they get their gas, and it's a roller dog. So there isn't really good infrastructure there. We also looked at the availability of healthcare in those areas. So we're really looking at, you know, how far do they have to drive even to just get a vaccine? We saw a big difference in that with the Indian Health Services and about 38 other communities. They really were able to keep the vaccination rates better because they actually moved into those areas and they were able to actually work on those areas and actually bring the infrastructure to those communities. Whereas I think that's the biggest problem during the whole pandemic is just that availability. And of course, the transfers are just extremely sad because the mortality rate's almost 3 times higher every time you transfer a patient.
Yeah, thank you. On the accelerated spread of COVID and increased death rate, I'm wondering if you could say a little bit too about other socioeconomic factors that you think accelerated the spread of COVID.
Well, the biggest one we saw was actually when we looked at, the first measure we looked at within ARC's registry was insurance. So how much was actually employer plans? So in the areas that had very high spread, we saw very few employer health plans at all. And so they're very dependent on the public services available. And a lot of that has to do with employment in a lot of these rural areas. So we see very few of them have full-time jobs. I know in the county I'm in, the Rocky Mountains, only 12% of folks in here have full-time jobs. So it's very seasonal. So you have a ski instructor who works in the ski area in the wintertime, and then he's digging up dirt in the summertime, and then he's a volunteer fireman. So these folks typically have between 2 to 5 jobs. So that makes it very difficult for those folks. Same thing in Dallas, you know, when it rains, the construction framers are doing moving work. When the moving work's slow, next thing you know, they're doing Uber Eats driving. So they all are working many jobs which offer few benefits. And a really interesting corollary to that was Kaiser just came out with a really good survey that showed folks that make less than $40,000 a year that only 8% of them had employers that would actually compensate them to get vaccinated or even their children vaccinated. So a lot of that goes into added access issues that we have to deal with.
Thank you. We'll have time for more questions a little bit at the end here, but why don't we go on to our third presenter. Megan Todd is a demographer and epidemiologist at the Philadelphia Department of Public Health, where she leads the Public Health Data Lab in the Division of Chronic Disease and Injury Prevention. She studies population health, mortality, health disparities, injuries, and aging. And today she's presenting on understanding disparities in hypertension, multiple data sources, and the promise of data integration. Megan, take it away.
Hi, everyone. Thanks to Sara and the conference organizers for putting together this session on population health science. I'm a demographer and epidemiologist at the Department of Public Health in Philadelphia. And I wanted to share a little bit with you about a project we're working on to leverage different data sources to understand hypertension and disparities in hypertension that we see in the city of Philadelphia. This is work joint with a number of collaborators at the health department. So hypertension is an important risk factor for a number of life-threatening conditions like heart attack, stroke, kidney failure, and it's really common. About 1 in 3 US adults have hypertension. We also see big disparities by race ethnicity, with the biggest differences showing up between Black and white Americans, where hypertension is far more prevalent among Black Americans than white Americans. Hypertension can be hard to measure. It's sometimes called the silent killer because it can be asymptomatic until it presents in one of these more serious health outcomes. But hypertension is controllable. So if we get high quality primary care, in theory, we should be able to reduce the negative outcomes that we're seeing from hypertension. And so in this project, like I said, what we're trying to do is learn a little bit more about hypertension and hypertension disparities by looking at different sources of data. So we're in Philadelphia, which for those of you who don't know, it's one of the largest cities in the US, with 1.6 million residents. It's very diverse. The population is about 40% non-Hispanic Black, about 34% white, about 15% Hispanic, and 7% Asian. It's a very poor city. About 1 in 4 residents live in poverty. That's about double the national rate. And there's lots of healthcare in Philadelphia. There are a lot of hospital systems. And so, you know, just the presence of healthcare is not a problem that we're facing in Philadelphia. Okay, so what kind of data do we want when we're looking at hypertension and hypertension disparities? Well, the dream would be that we have some very large representative sample. It might include self-reports of who's been diagnosed with hypertension, as well as measured biomarkers where we might actually measure blood pressure, so we can capture those folks who don't even know they have hypertension. And ideally, we'd follow the same people over time, so we could see kind of what happens to them over months and years. Of course, the reality is not like that. What we are instead doing is kind of piecing together imperfect data sources, like telephone surveys and administrative data from hospitalization information or for vital statistics. So I'm going to talk a little bit about each of the sources that we have available to think about these hypertension disparities. Okay, so first, a telephone survey. So this is where we call up a bunch of people and we say, have you ever been diagnosed with, in this case, hypertension? So the BRFIS, or the Behavioral Risk Factor Surveillance Survey, is one of the biggest health telephone surveys in the country. They talk to about 400,000 people a year. In Philadelphia, it's somewhere between 700 and 1,200 each year. So it's really big, it's representative, it's conducted every year, and it's a collaboration between the CDC and state health departments. So it means you have nice comparability between different states. Now, one of the weaknesses in the telephone survey, of course, is that you only talk to who answers the phone. And so there's a question about representativeness and bias there in terms of who you get to speak to. And so the worry here is that we might actually be underestimating disparities by relying on this telephone sample. So looking at results from BRFIS in Philadelphia, this is looking at, have you ever been diagnosed with hypertension? And what we see is there are pretty big disparities by race and ethnicity. So if we look at the panel on the left, among women, the light blue bar is non-Hispanic Black women, and then the kind of medium bar is non-Hispanic white women. And you can see that the rate among women for hypertension is about 45% for Black women and about 27% for white women. So that's a difference of about 60%. The differences are a bit smaller on the right panel when we're looking at men, where the telephone survey tells us that hypertension is about 35% more prevalent among Black men than Black women. Sorry, Black men than white men. Okay, so if we're concerned about some of the biases that might be introduced with a telephone survey, we're worried that some people might not have access to health care, and so they don't have a doctor who can tell them that they're hypertensive, or maybe they did go to the doctor, but they might have low health literacy or language skills, so maybe they didn't really understand what the doctor said or remember what the doctor said. So then we might want to turn to some other data. So here we're looking at administrative data on hospitalization discharges. This is from the Pennsylvania Healthcare Cost Containment Council, or PIC4, which is a state agency that collects data on healthcare costs. We get quarterly discharge data that includes a bunch of information about patient demographic characteristics, diagnoses, and we receive those data about a year later after the hospitalization happens. So our first finding is that the citywide annual rate of hypertension hospitalizations in Philadelphia is 135 per 100,000 residents. And we're interested in disparities. So by linking this hospitalization data to census data, we can start calculating rates by sex or race and ethnicity. So here we have women on the left panel, and we're comparing the rate of hypertension hospitalizations among Black women to the rate among white women. So Black women is the tall light blue bar, and white women are the smaller dark blue bar. And you can see that the rate of hospitalization is about 3 times larger among Black women than among white women. And the panel on the right, we have the rates for men, and there's a similar disparity between white men and Black men. Okay, so since we have zip code from the hospitalization data, we can then link that to other census data and say something about the neighborhoods in which hypertension hospitalizations are more and less common. So here we're looking at the rate of hospitalizations along with the predominant race or ethnic group in the different zip codes in Philadelphia, and we find that hospitalizations are more common in neighborhoods that are predominantly Black compared to those that are predominantly white. And then we can start thinking about other characteristics of those zip codes. So here we're looking by median income. And you can see that the rate of hypertension hospitalizations is a lot higher in low-income zip codes. That's in the kind of coral pink color on the left, compared to the middle-income zip codes and the high-income zip codes. And then one more linkage that I want to share, which is brand new. We just got this linkage that connects those hospital discharge data to vitals records. So this is a pilot project, first time we've ever done it. We have about 5 years of data where we linked hospitalizations to births and deaths that happen to those patients subsequent to their hospital stay. And so we can learn a lot from this linkage, because if we're focusing just on the hospitalization data, so in this example, we're thinking about just 2016 and 2017, we know there were about 2,400 patients who were hospitalized. And in the hospital discharge data, we know that 6 died in hospital, but we don't know very much about what happened to all the other patients. We know something based on discharge status, so they could have been sent home or to another medical facility or home with some kind of health care. But then we don't know what happened after that. Now with this linkage to vitals data, we can find that actually 13% of those patients go on to die by the end of 2018. So this is with 1 to 2 years of follow-up. And so thinking about the timing of this, here we're looking at among patients who we do observe in the death certificate, so we know they died, when did they die? And what you can see is that when we're looking at all hospitalizations, a good chunk of them happen in the hospital in the gray, or shortly after in the orange. But that's not what happens with hypertension hospitalizations, where actually for those deaths that we do see, they really tend to be later in the follow-up period. So the dark blue and the light blue, more than 6 months or even more than a year later. So summing this all up, we see disparities everywhere, and these different data sources kind of give us different insights and ask slightly different questions. Telephone surveys say, who knows they've been diagnosed with hypertension? We see that's more common among Black Philadelphians than white Philadelphians. When we look at the hospital discharge data plus the census data, we can compare who has severe uncontrolled hypertension and what their neighborhoods are like. So we see that it's more common among Black Philadelphians and white Philadelphians. It occurs at younger ages for Black Philadelphians. And it happens more frequently in neighborhoods that are Black and lower income. And so then adding this vitals data, we can start to understand what happens after the hospitalization. For whom does the hospitalization lead eventually to death? Again, very preliminary, we're seeing that it's happening more frequently among Black Philadelphians and at younger ages. All right, so thanks. I look forward to hearing questions and comments.
Great, thank you, Megan. while our audience is typing their questions in chat, I'll kick it off with one. You showed pretty clearly that race was associated with rates of hypertension, hospitalizations, death, much detail within that. I'm wondering if you could speak a little bit about how disparities accumulate along the pathway from racism to hypertension, hospitalizations, and death that you were able to see in the data sources you had linked there.
Yeah. So, these different pieces kind of get at different steps along the pathway. So you can think about, one thing we're really missing in these data are folks who don't yet know they have hypertension. So folks who may have live in unhealthy neighborhoods or, live in areas with lots of secondhand smoke, those kinds of things that lead to hypertension. What we can measure is folks who go to the doctor and have a doctor tell them they had a hypertension. That's not the same as actually having hypertension, but we can get to that point. And then a little bit further down the chain, we can say, okay, well, what about when hypertension gets so bad that you have a hospitalization for hypertension, which should never happen. That should be preventable if you have good primary care. And so then we're kind of saying, okay, for a bit further down the chain, there should have been good access to primary care, but that didn't happen. So now where are we seeing that kind of really play out? And then of course, linking to vitals data, we can think about, the worst outcome of this after a hospitalization, which shouldn't have happened. How did it, for whom did that lead to a death following that hospitalization? So you can kind of think about different steps along the path there. And the one that's really hard to get at is that very first piece. If we went out and randomly selected a bunch of people and took their blood pressure, we might have a better sense of, true rates of hypertension.
Thank you. I'm seeing a couple questions in chat about the linkage that you did with death records. Wondering if you could speak a little bit more about the methodology you used to perform that linkage to death records and how accurate it was.
Yeah, so when I said it was brand new, I meant it. So there's kind of a lot of work we still need to do to kind of understand exactly how good that linkage is. And it's kind of, right now we're working through some of the same things that you always see when you're working with a new data source, so, the age of the patient doesn't correspond when we link the death records to the hospital records, or the race ethnicity doesn't match. Or, we have patients where when we link to their death certificate, the death certificate says they died before the hospitalization occurred. So, we have a bunch of weird things like that we kind of need to work through. But we think it's pretty good. And how this linkage is done is we have, death certificates identifiable with names and social security numbers and addresses that is then sent to the PIC4 group that uses their data. So all the data that they have from hospital admissions. And so they can match on a lot of those identifiable characteristics. Of course, we don't get those identifiable information back. But we think they're pretty good. And then just looking one step forward, these were deterministic.
So you had social security or other unique patient identifiers then?
Yeah.
Great. And let's see, sorry, I'm going back up to Myron's question here. Did you have reliable cause of death information? And if so, how related to hypertension was that?
Yeah, so that's the next question that I want to ask. So we do have pretty good cause of death information. We have underlying cause of death and contributing causes of death. And that's, next on my list, but I haven't gotten to it yet.
Great. This actually would be a great time to bring all of our presenters back. I think there's some interesting questions that I would like to ask of all of you, in addition to those that are in chat here. And so I guess my first one would be about thinking, the title of the session is about population health and linkages. Wondering what you think about the feasibility and value of ongoing versus one-time linkages. thinking about the effort that it takes to set up a reoccurring linkage between multiple data sources versus a one-time linkage for one particular use case. Megan, I'll throw it to you first.
Yeah, sure. I mean, the hope is that we'll be able to get, so thinking about this linkage that we did between hospitalization data and vitals data, this one-time use, we're looking at just hospitalizations that occurred between 2013 and 2018 and deaths that happened in that same time period. So especially for those later years, 2017, 2018, we just don't have very much follow-up. So like, we're just not going to see that many deaths. So I think the value of this linkage will come when we can update it in a few years, and we'll have actually seen more action in mortality. We will have seen more deaths, and we can start asking more things about what the causes of death and what happened with numbers that are large enough to feel that we can feel confident in.
Félice?
Yeah, I agree. I think having ongoing linkages has clear benefits in terms of sample size and also being able to track things over time. I think having some sort of, although there's a lot of initial work in getting a system with ongoing linkage going, I think there's this huge payoff in terms of being able to be nimble and responsive and actually more directly affect care or program planning or implementation, rather than go through the process of legal and logistic and technical negotiations and processes each time, which creates often a several year delay in the data, which means that the use of the data, I'm an academic, so I can publish a paper and that's great, but if you really want to be using the data to improve care, it's just not useful with that kind of a delay.
That's great. Ernie?
Well, I think it's a really good thing to have. I was really impressed when the CDC came out with their vaccination data. So instead of just county data that shows vaccination rates by different age groups, they added the SVI in there already. So they're starting to look at this relationship just within vaccinations, because we know it's pretty significant. So I think that's important. I know our own company, we've been looking at this data for the last year, and we're looking at building a vulnerability index, because quite a few of our hospitals are always trying to look at how can I improve compared to this hospital versus this hospital. And you'd be surprised, there's some hospitals that are in very suburban areas. They don't really have to deal with a lot of these social determinants of health compared to other ones where literally that's 80% of the patients coming through the door. So I think it's really good that we can add these in there so they can really go out there and start to collaborate with other hospitals that are dealing with the same type of patient characteristics within their community.
Yeah, that's great. And that kind of leads on to another question about, we cite one of the primary reasons for these linkages of being able to identify disparities and being able to identify differences in socioeconomic, race, language, all the ways we can define a population. So I want to go back to Sylvia's question earlier about the conceptual definition of disadvantaged, or the impact of that. And so she I'm just going to read it because she said it nicely. How should we define or characterize the type of disparity where outcomes of the advantaged deteriorate to those of the disadvantaged, as we have seen as a result of the opioid epidemic?
Yeah, I mean, that's a really, can I go ahead and jump in? And yeah, I think that's a really excellent point. And it's one of the, I think, great struggles of both research and public health, research on disparities and public health efforts to reduce disparities, because you can't have an either or goal. You have to have a both and goal of reducing disparities, but also improving outcomes for everybody. So if you look at one without the other, you miss that, right? Clearly it is, conceptually, we would want to reduce disparities in mortality, but we absolutely do not want to do that by making outcomes worse for those who initially have the better outcomes. And for example, even the obesity by maternal education information that I showed, what is underlying that is that there's actually increasing prevalence of obesity among the entire patient population over time. So I don't have, to be honest, I don't think there's a great vocabulary for that distinction, but I think it's a really important one to have, where you cannot look at disparities independent of looking at the within group and the overall trends as well.
Thanks. Megan or Ernie, any thoughts about that?
Well, I'll just say I think equity is a very expansive area, so there's lots of different rabbit holes. There's lots of different ways we can define it. And I think that we really need to get more national leadership around that. And I think it's good that a lot of the groups like CDC are starting to actually put this into their analytics, because it'll make it, at least we'll have something that we can compare it to and start to improve it and move better.
And a little plug, if you go back and watch the symposium videos from Friday of this NAUTO conference, there were some great approaches and methodology shared there. We'd like to go to Sarah's question about how you have approached some of the legal obstacles associated with linking data sets. Maybe you want to take that one first?
Sure, I can. And I think you could probably tell by the way we're all laughing that it's pretty big part of what we do. So I work for the city of Philadelphia. So we have a whole legal department that gets involved anytime we want to link data like this. And that's great, because it means we're being really careful about our data governance and we're being careful to maintain privacy. But it also means that you have an idea for a project that's really relevant and it gets through legal in 12 plus months. And so, for example, this vitals linkage that we did with hospitalization data, when I first started in this position 2 years ago, it was, it's got to get approved and we'll have it any day. But it came just a few months ago. So, it's a big challenge. And I think one that, like, being at a city agency, we're particularly cautious about and very leery of. I know Félice has also faced the city of Philadelphia's privacy concerns, and it can really slow things down. It's tough for city officials compared to researchers, because we are really beholden to the population and to our residents. And we can't, keeping that trust is the most important thing for someone in my position, which may differ a little bit from other folks.
Ernie, I saw you nodding on that one. Thoughts on the obstacles?
Well, every analysis that we do, we do research requests with, doctors at, over 500 different institutions. So we're constantly, but we have to go to data governance on every single one of them. So we take it seriously. And then a lot of times data governance says, well, I got to go talk to legal. We always hate hearing those words. We have to talk to legal because we know it's going to be 6 months, but we try to streamline it as best we can. We try to be sensitive to it.
All right, we've got time for one last question here. Wondering what you think of Jacob's question here about the role that claims data can play by linking them to more traditional data sources, such as surveys, to deliver insight about the health of a community or population. Do you think this shows promise?
I would agree. Yeah, I mean, we're doing one with medical schools right now, taking some of their survey data along with some of our clinical outcomes data to actually look at educational opportunities. So I think those are really good ways to integrate data.
Yeah, I mean, and I would just say that I think it's essential, because you can ask and answer different questions with claims data than you can with survey data, than you can with population data, than you can with census data. And, asking the question, by letting the data source frame how you ask a question, it biases the answer that you're going to get. And so I think it's really important to be thinking about those biases that are built into different kinds of data sources and trying to triangulate from different points and think about what really you're measuring. What aspect of what you're trying to measure are you actually measuring, and how well are you able to do that?
Félice, any last thoughts from you on that one?
No, I absolutely agree. I mean, I think we're all touching little pieces of the elephant, right? So as many pieces as you can get, the better idea you're going to get the whole elephant.
That's great. And I think we're at time. So thank you all for coming today. Panelists, thank you for your excellent work and great presentations, and enjoy the rest of the conference.
Yep, you too. Bye-bye.